Our next speaker will be Dr. Samir Rigal. He's talk about a challenging case, a pseudocarotid aneurysm, a case presentation.
Good afternoon. I'm going to talk today about carotid artery pseudoaneurysm case presentation. Of course, as we know that carotid artery pseudoaneurysm are rare and potentially lethal, and adequate treatment is warranted in order to prevent rupture or neurological sequelae. As if all know, etiological factors are diverse, and they include trauma, iatrogenic, mainly after endarterectomy, dissection, infection, vasculitis, and others. Many meta-analysis studies have revealed that pseudoaneurysms are significantly outnumber the true aneurysm, especially in the extracranial carotid arteries. They constitute about 90% of total aneurysm at these locations. These aneurysms can be focal, saccular, involving short segment of the artery, or they can be fusiform and involving a long segment. About clinical presentation of these pseudoaneurysms, it varies depending on the etiology, size, location of this aneurysm, and the main presentation feature includes stroke, transient ischemic attacks, pulsatile mass or lesion, Berwick, thrill, or cranial nerve pulses that lead to voice changes, Horner syndrome, and other compressive manifestations like difficulty in swallowing, breathing, and the most featured presentation is rupture into the airways. About mycotic aneurysm, the most common pathogen in our staph areas, Streptococcus pyogenes. They are the most infective organism at the formation of these pseudoaneurysms. Histological changes of mycotic aneurysm include acute arthritis, involvement of vasa vasorum, ischemic changes, which lead to enlargement of the wall and can lead to bleeding or hemorrhage. As we know all, the conventional treatment of these pseudoaneurysms is resection and placement of prosthetic or autogenous vein graft. Although the surgery is an effective treatment method, it's technically a complicated procedure that requires much experience, and complications such as cranial nerve palsy, stroke, rupture during surgery, or leakage into the surgical area can occur. The rate of stroke or death during surgery is reported to be between 9 to 15%, and the incidence of cranial nerve injuries is reported to be as high as 15%. Recently, endovascular techniques have been utilized to treat many cases of pseudoaneurysm, like post-traumatic or post-carotid endarterectomy. Endovascular approach is less invasive, with lower risk of immediate stroke or nerve injury. However, its durability and feasibility is unknown. Here are some examples of case reports in many papers. The operative field, operating in a field with distorted anatomy due to previous surgery, inaccessible distal endpoint, short neck, occluded contralateral internal carotid artery were challenging factors for open surgery in these cases. However, endovascular treatment for infected carotid aneurysm has been described in the literature for exceedingly high-risk patients. The major benefit of such approach is to operate under local anesthesia and to avoid reoperative field. This is virtually eliminate the risk of cranial nerve injury. As we know, the use of the cover stent for treatment of carotid pseudoaneurysm is certainly not without risk. Given the presence of thrombus, the risk of embolization during passage of guide wires and development of device must always be considered. The presence of unstable thrombus within the pseudoaneurysm may be considered a relative contraindication for endovascular repair and mandate distal protection device. In addition, there exists the possibility of graft thrombosis due to improper seating within the aneurysm sac or poor adaptation of the device to the carotid walls. Our case today is a male patient, 47 years old. Medical history was irrelevant. There was a past history of submandibular operation 2 years ago for unknown pathology for swelling in the submandibular region. After that, multiple neck sinuses were developed since this operation, and he received multiple courses of antibiotics. Patient who presented to us with sudden painful neck swelling 2 days ago. And here the patient looks like with multiple neck sinuses with sudden painful swelling at the neck. By examining the patient, he showed right neck swelling with pulsatile mass suggested to be carotid artery aneurysm. Duplex examination showed pseudoaneurysm of right internal carotid artery with hematoma around the artery suggesting that this aneurysm is leaking. Bacterial culture was done from discharging sinuses, and appropriate antibiotics were given to this patient. Here is the preoperative CT angiography, shows the pseudoaneurysm at the right internal carotid artery. We proceed to the operation. Here is the intraoperative angiography. We use 35.35 trauma wire as the usual way from the femoral approach to the right internal carotid artery, passing the right common carotid artery. A balloon-mounted covered stent B graft was deployed across this aneurysm. Here is the intraoperative angiography, and we see here maybe post-stent stenosis which was dilated. 1 week later, surgical exploration was done for evacuation of the hematoma at the neck and excision of pre-existing neck sinuses. Here is the follow-up after 6 months, which shows patent graft and exclusion of this pseudoaneurysm. We conclude that due to lack of adequate guidelines and operative experience, there is no consensus about the treatment planning for the pseudoaneurysm. Treating physician can choose between surgical treatment and endovascular treatment options, depending on size, location, extent, and etiology of the aneurysm, and general condition of these patients. The experience of the operating surgeon and interventionist is an important deciding factor. Thank you.
Thank you, Dr. Samir.